When I first went to the UCSI, before you started. Yeah. So much better than I was. Not working.
I'm gonna do both readings and drill. Is that okay? Sorry. Oh, thank you. Okay, should we start?
Absolutely.
Okay, do I need to, Nicole, do I need to do anything IT wise or are we live? We're good? Oh, I'm not live. Oh, I am live. So the mic is, oh, I'm live, but not mic up.
Yeah, Zoom.
So now people can hear?
Yeah.
Yeah, they can hear for Jessica, yeah, they can hear, okay. Okay. So welcome, everybody. I have the pleasure, I'm Phoebe Greer, I have the pleasure of introducing Jessica Leung, coming to us from MD Anderson. This is a huge deal. Jessica, I first heard of, I'm gonna go a little rogue from her intro, but I first heard about her when I was interviewing for fellowships and she was teaching at UCSF, and all you ever heard was, wow, if you get to learn from Jessica Leung, go learn from her. She is a brilliant teacher. She is amazing. She's one of the best clinical radiologists that exists, and she's an academic powerhouse. So that is, you know, the unofficial. And then I've had the pleasure of working with her quite closely through ACR, SBI, Breast Cancer Screening Leadership Group, and through other committees. And she is just an absolute gem. We are so lucky to have her here. She's a full professor of radiology, and she's the deputy chair of the Department of Breast Imaging at MD Anderson. Prior to being at MD Anderson, she actually trained Harvard Medical School and Harvard undergrad, graduating summa cum laude because she couldn't just graduate Harvard. And then she did her residency out at UCSF and breast imaging fellowship at UCSF. She had done her internship at MGH. So she has been at multiple academic powerhouses, as well as clinical powerhouses, especially for breast imaging. She is also super involved with the SBI. She's a fellow of American College of Radiology and fellow of Society of Breast Imaging. She is over 125 publications, over 500 lectures on 5 different continents. She's the faculty wellness lead for the Division of Diagnostic Radiology at MD Anderson. And she is the past president of the SBI. She's currently on multiple committees at the SBI, including the membership committee, on the International Education Committee. She's been super involved through education throughout her entire career. She has won UCSF Teacher of the Year award. She's been a American Rankin Rice Society Scholar, the George R. Leopold Lecturer, UCSF Outstanding Alumnus, MD Anderson Diagnostic Imaging Outstanding Extramural Science Award, and MD Anderson Editor of a large comprehensive, MD Anderson Diagnostic Imaging Outstanding Educator. She is also co-editor of a large comprehensive textbook, I think being co-authored by our own Nicole Winkler, who is also assisting with that. And she's a founding member of the ACR Screening Leadership Group, as I said, which is where I've gotten to work with her closely. She's also a member of the ACR BIRADS committee, which is exciting because the new BIRADS edition is coming out. Shortly, it's in review right now, and she's chairing the BIRADS ultrasound section. She's also chair of the ACR Stereo Biopsy Accreditation Committee. So everybody, please welcome Jessica Leung and listen to what she has to say.
Thank you. Thank you, Dr. Freer, Phoebe. So such an honor for me to be here. I'm going to try to turn this on. You help me figure that out, but you can hear me anyway, right? Loud enough. What a gorgeous place. I feel like I'm on vacation in some resort, and it's going to have all kinds of wonderful times in the next 2 hours. I think, and thank you so much for being here. I know everybody's busy. And of course to Dr. Winkler, Nicole and Dr. Freer, Phoebe for inviting me here. Such an honor. Of course, this is the famous Huntsman Institute and also is the city where High School Musical was filmed, right? Okay, and I'm talking about 1, 2, and 3. I don't think there's a 4, okay? And seeing my former teacher and great friend, Scott Evans, thank you for being here. Okay, so on that note, lymph node and breast cancer advances in imaging assessment. So this is my disclosure. So nodal evaluation in breast cancer. Why does it matter? Well, it matters because most breast cancers metastasize via the lymphatic and not the hematogenous system. Okay. So this is data that is classic from the clinical literature. And here you have a schematic drawing, if you will, of the lymphatic system, the breast with the lymph nodes and the lymphatic channels, and long-term follow-up data. We're looking here at years of diagnosis, 20 years after the diagnosis, and here are your survival curves on the y-axis. 100% survival on top, going down to 0 on the bottom. And of course, you want these curves to be as long survival as possible. So you want to be on this curve among the curves that are shown here, which is the one marked by the square with 0 nodal involvement at the time of diagnosis. When you get to a lot of nodes at the time of diagnosis, let's say this triangle, which is 4 to 9 nodes, versus this X mark, which is 10 plus nodes, the curves are down here with much lower survival. Okay, this is data. We know that over a long-term follow-up. This publication showed 20-year follow-up, and of course, we know that from everyday clinical practice that we experience. So lymph nodes matter. And here's data from the FACR tumor registry. FACR is surveillance epidemiology and results, arguably the most sort of respected tumor database in the United States. And remember, in the United States, we have a screening mammography program. Of course, arguably, we can always improve access, but in theory, at least, this is something that should be available to every woman in the United States under the Affordable Care Act. But even in a situation where we do have a screening mammography program, you'll see that the tumor registry shows that when cancers are diagnosed, a good 29%, okay? So that's close to a third is diagnosed at the time of regional disease. Regional disease being defined as disease in the breast and spread to the regional lymph nodes already. Okay? We want our patients to be in the breast only, which is 63%, but we have a good, 29%, right? That's not a low number. That's already spread to the regional lymph nodes at the time of diagnosis, even in a country where we have screening mammography. So we want to be able to study the lymph nodes and understand them well. Okay, so here we have the AJCC Cancer Staging Manual. This is the most recent edition, which is the 8th edition. And in this is the first time we're introducing something called a clinical prognostic stage. This is in addition to the anatomic stage. I'm going to talk a little bit about this with the residents during the next hour after this. But the TNM staging, of course, is what most of us are familiar with, and that's the anatomic stage. And of course, TNM staging also extends to other cancers, not just breast. And we'll take a closer look at this. And here is the TNM staging. Okay. T stands for primary tumor, so that's what's the tumor that's in the breast. And of course, M is distant metastasis, like other cancer systems. M0 is no distant metastasis, and M1 there is distant metastasis. And by definition, M1 is stage 4, right? And which is poor prognosis. So of course, we want to diagnose breast cancers through screening much earlier than that. The N is what we'll focus on for the better part of this lecture. And that is the nodal status, N for nodes, okay? And notice that this is regional nodes, nodes that are close to the breast. And I'll define exactly what regional nodes are. The bottom line is that you combine the T and the N and the M information, and you get your anatomic stage. And as we know, stage impacts survival, predicts survival a great deal, so stage really matters. And let's take a little closer look at the TNM staging. We'll focus here on the N part for this lecture, okay? And the N, the number matters. You can have N0 to N3. And the number of lymph nodes matter. Of course, the greater the number is the more advanced end stage. The more advanced end stage, the more advanced overall anatomic stage and poor prognosis. And that, of course, is very, very important information for our clinical colleagues to guide management and for them to help patients prognosticate. So the number of nodes matter. Let's take a quick review at the sort of schematic drawing, if you will, of a lymph node. So here is your lymph node, kind of happy, enjoying the Utah sun here at noontime. Okay, so here you have what we call oval or reniform, which is kidney bean shaped. And here you have afferent lymphatic channels, and you have efferent lymphatic channels going in and going out of the lymph nodes. And here is the outer part, the periphery or the cortex, and you have your follicles there. And then in the middle, you have your fatty hilum, mostly fat. Okay, so this is a very rough, and very basic reminder of what the lymph node is. And you can imagine that if you have tumor cells circulating in the body, going from the afferent channel, you can get trapped here among these follicles, among these lymphocytes. And you can have enlargement, distortion of the shape, maybe compression of the fatty hilum. So all those things lead to morphologic changes that we see as radiologists in our cancer patients. Okay. And just normal anatomy, you have your artery and vein here, and we can see that often on Doppler interrogation when we do ultrasound. So this is just a reminder of what normal anatomy looks like. So you have to know normal, of course, right? Before you know what's abnormal. So when is it normal and when is it not normal? So let's look at a benign, i.e. normal, intramammary lymph node. Okay, ultrasound, we see those beautifully, and here we have ultrasound images of that. On the left, you have longitudinal, on the right, you have your transverse, and you have your cortex there, which is hypoechoic, thin. You have your fatty hilum in the middle, which is echogenic. So these are very normal appearing intramammary lymph nodes. And here I show you the Doppler, the artery and the vein, again, part of normal anatomy, normal hilar flow. So that's an intramammary lymph node, benign appearing. So this is the normal axillary node, okay, a little bigger, but the principle is still the same, which is that you have your uniform hypoechoic cortex, thin, symmetric, and then you have lots of echogenic fat here, which is, very normal looking. So we can feel, well, sure, that's a BI-RADS 2 benign finding. So that's normal. But how about this? This is when your normal axillary lymph node goes rogue and becomes abnormal. Okay, it's rebelling. It has a cancer involvement, is what I'm trying to say. You can see that maybe this is the normal cortex at one time, but then this part here, this eccentric cortical thickening, right? You know it when you see it, and you recognize this is too thick, and this is in the setting of ipsilateral breast cancer, you're talking about involvement, nodal involvement. Okay, so this is an abnormal axillary node. And let's take a look at the Doppler part. You see that? Remember I said that you have normal hilar flow? Well, this is not hilar flow anymore, right? This is, cortical peripheral flow. And this is too much. And while that's not specific for cancer only, you worry about it, especially when you have an ipsilateral breast cancer. So that's abnormal peripheral cortical flow and not normal hilar flow. The whole point of this is to say what's normal and what's normal, abnormal. Okay. All right. So at MD Anderson, there's long interest in lymph nodes. And this is a while ago now, 2008, and I see many young people in the room. I'm very happy to see that. And I'm going to say some of you, were you all born by 2008? Please tell me you are, okay? So 2008, this publication, and it's a multidisciplinary with surgeons, pathologists, radiologists, et cetera. The lymph nodes were actually removed from the patient's body and scanned in vivo in a bucket of saline, okay, and seeing what they look like and correlating that with pathology. So to give us some idea of what's normal and what's abnormal in a sort of more structured way. Okay, so long story short from this is that these were the conclusions. Size is not the most important. Okay, and we say that. I mean, I know size is the most important when it comes to diamonds. Okay, remember that. Okay, size bigger is always better. But size is not the most important when it comes to lymph nodes. You can have very big lymph nodes that has a big fatty hilum, and that's perfectly normal. Cortical thickness is important. And the ultrasound literature has shown through the years that 3 millimeters is a nice cutoff for what's abnormal versus normal. And of course, everything's a spectrum. Nothing is 100% specific. So 4 millimeters, 5 millimeters could be just fine. Doesn't mean it's cancer, but you start to worry more when it's more than 3 millimeters. Now, notice that's been validated only for ultrasound. And Dr. Freer, in her very nice introduction, thank you very much for that, explained that I'm working on BI-RADS, right? And the next edition of BI-RADS is going to have a lot more discussion on lymph nodes, and both ultrasound and MRI in particular. And on the ultrasound part, we're going to adopt 3 millimeters as the cutoff, because that's been validated. But an MRI that has not been validated, and the MR section is going to say that specifically. That while 3 millimeters may be a cutoff ultrasound, that's not validated in MRI. And you're gonna say, well, what is the cutoff MRI? No number. MRI is gonna suggest that you look at symmetry between the two sides to determine what's normal versus abnormal. Okay, so that's a quick discussion about what's upcoming in the 6th edition of BIRADS. What is important is focal or essential cortical thickening. That is suspicious. Cortical hypoechogenicity at ultrasound, that is really, really, really dark. You know how you have triple negative breast cancers and those can look really, really dark? Okay, I think the same kind of event is happening in the lymph nodes. That when you get really, really dark, you have like monotonous cell populations, more suggestive of tumor rather than a heterogeneous population of lymphocytes and other cells. So cortical hypoechogenicity is a sign that you have some abnormality in the node. Loss or effacement of the fatty hilum, when you have those morphologic changes, abnormally round or irregular shape. Normally it should be oval or reniform shape. When you have calcifications, and I mean calcifications that are like calcifications, in the breast, when you have suspicious calcifications, and that peripheral blood flow that I already showed. Okay, so these have all shown to be, especially ultrasound signs that are worrisome for malignant involvement. So in the 2008 in vivo study involving lymph nodes that were removed from the patients, a classification system came about. And we discussed whether this should be part of the BIRADS. Okay, so the conclusion is no, this will not be part of BIRADS, meaning you're not going to say type 1, type 2, type 3, we're not going to do that. And really, to tell you at MD Anderson, we don't use the words type 1, type 2, type 3 in our reports, okay? But what I want to introduce here, I want to introduce the concept here just to show you how to interpret the data, but also to show you sort of the spectrum of change. And of course, it is the morphologic spectrum of change that is important. So type 1 and type 2 is basically normal. You have either zero, imperceptible cortex, just all fat, all hilum, or just a little thin rib, 3 millimeters or less, okay? Now type 3 and type 4 gets a little into the gray zone, a little murkier, if you will. And it's type 3 is uniform, but it's thicker than 3 millimeters. And type 4, it looks a little lumpy bumpy, generalized lobulated hypoechoic cortex. Type 5 is when you get into worrisome category. You have bump, T for tumor, right? Wouldn't it be great if AI could label all images like this? T for tumor, H for hilum, etc. That's a focal hypoechoic cortical lobulation. Type 6 is when you have complete tumor invasion, no fatty hilum visible. Okay, so you can see the spectrum, and it's not so important you say, oh, that's a type 5, but just keep in mind the spectrum of changes. Because here's the data in that 2008 article. So type 5 and type 6, this was the PPV, a positive predictive value. And the numbers here are not like super crazy high. They're not like, 90% that'll like take to Vegas with me or anything, those numbers. But you can see that the numbers are all greater than the magic mark of 2%. Now, why is 2% a magic mark? Does anyone know? And I know some of you know, okay? 2% is a magic mark because that's the cutoff between BIRADS category 3, probably benign, and BIRADS 4 suspicious. And BIRADS 4 suspicious, we would do a biopsy, right? So anything over 2%, in theory, we're considering biopsy. So while these numbers are not like 90%, they're definitely over 2%. So we're gonna biopsy type 5 and 6, right? I think no argument there. Okay, so type 5 and 6, sufficiently high to warrant biopsy to exclude cancer. So 3 minus, this is type 5, and this is type 6 with complete effacement of the fatty hilum. Okay, let's now look at 1, 2, 3, and 4. And we'll look at, instead of the positive predictive value, we'll look at the negative predictive value. How often is that not a cancer involvement? And you look at type 1 and type 2, wow, the numbers are 100%. That's like really good, right? Or as my 10-year-old nephew would say, that's super good, okay? Nothing in life gets better than 100% negative predictive value. Like what I think is the perfect movie star, Keanu Reeves. You guys know Keanu Reeves? Okay, well, thank you. Even the young people in the back, not that Dr. Parkinson, you're very young too. I wouldn't include you, okay? Who gives money to philanthropy, etc. Nothing in life, maybe except for Keanu Reeves, gets as good as 100% negative predictive value, right? So negative predictive value, we don't need to biopsy 1 and 2. But what about 3 and 4? These are the PP negative predictive values, okay, in this study at least. Ugh. Are they high enough that you don't need to biopsy them? So to biopsy or not to biopsy? So on that note, let's take a little break, okay? And does anyone know this actor?
Mel Gibson.
Mel Gibson, okay, young Mel Gibson in his early days, before a lot of controversy later on, okay? So young Mel Gibson, and one of his, apparently this is one of his most like roles that he got a lot of praise for as an actor, you know, as a stage actor particularly. And the movie is Hamlet. I know Dr. Evans would know all this. Mel Gibson, 1990 Hamlet, Francis Zeffirelli. So, you know, to be or not to be, to biopsy, not to biopsy, get it? That's the best I could come up with. Okay, yeah. So to biopsy or not to biopsy, type 3 and 4, I would say depends on your clinical scenario a great deal. But suffice it to say, for the purpose of today, to biopsy or not to biopsy, most of the time when we do staging patients with MD Anderson, we would, especially when she has a lobular carcinoma as her index cancer, and I'll show you some data on that. Okay, but if it is a, you know, if for whatever reason it is, we happen to see it on a screening case, then we may not. Okay, so kind of situation dependent, if you will. Okay, but type 1 and 2, no argument there. We don't need to biopsy them. And here on the type 1, really no, all fatty hilum and type 2, you know, just a thin hypoechoic cortex. These are normal. Negative predictive value, 100%, wonderful. Like Keanu Reeves, wonderful. Okay, all right. So that's a little review on the, you know, morphology. Again, I don't mean to hammer home the types, but just helps us, you know, as an educational tool. Okay. Now, anatomy matters in nodal staging. So this is another famous gentleman. Okay, yes, Da Vinci, Leonardo, and I don't mean, you know, we're not talking about DiCaprio, right? So it's Da Vinci, and kind of like Dr. Evans here, Leonardo da Vinci, the Renaissance man, who Dr. Evans, who does all kinds of radiology, okay? And Leonardo da Vinci was an artist, of course, the Sistine Chapel, the sculptor, etc. Also an anatomist, right? So this here is his famous Vitruvian man, circa 1492, you know, anatomy. He was actually an anatomist too. So that waylays into our discussion on anatomy of the lymph nodes. This is a review article from MD Anderson in 2014. Okay, so 2014, you're looking at 10 years ago. And I think it's interesting to bring that up because most of it has not changed in terms of the TNM component, but the terminology. This is the part I want to bring up by showing this article, because this talks about these being the regional nodal basins. And today it's still the same. The one difference is that instead of infraclavicular, which is the word used in this article, we now prefer to call it axillary level 3. Okay, and in the 6th edition of BIRADS, we're going to talk about the axilla levels 1, 2, and 3. We're not going to use the term infraclavicular. True for ultrasound and true for MRI of the BIRADS 6th edition. Okay, so regional nodal basins are axilla, which is defined in levels 1 and 2. Level 3, formerly known as infraclavicular, you know, kind of like, you know, the artist formerly known as Prince, yes, you know, we're not so close to Minnesota, but we're kind of, you know, those northern states here. Supraclavicular and internal memory, okay? These are the regional nodal basins. So 3 levels in the axilla, and we make a distinction at MD Anderson between the different levels, and sometimes we may clump 1 and 2 together, but we make a distinction between level 3, because axillary nodal dissection, which is considered to be the gold standard, right, for nodal staging using pathology, almost all surgeons do levels 1 and 2 only, and they don't go to 3, okay, in the routinely. Okay, so even though they do axillary nodal dissection, you're not really seeing the whole axilla, because routinely they don't go to 3 unless there's special reasons for it, because of the morbidity involved and, you know, invasive surgery, etc. So we tend to say, you know, axillary 1/2 nodes for all surgeons, and then 3 as a separate report. And we know that's is aligned with the TNM staging. This is 2014, so the word infraclavicular was used, but if you look at the TNM staging now, the N0 to N3 is the same with the substitution of the word infraclavicular. So N3C, for example, is ipsilateral supraclavicular versus N1 is only in the ipsilateral level 1 or 2. And you see how they clump level 1 or 2 as well? Okay, so also they recognize that 1 and 2 is basically the same in terms of prognosis and often management for our breast cancer patients. Does that make sense, everybody? Yeah, I know that's a very brief introduction. Location of nodes matter. I'm sure it matters in terms of Salt Lake City real estate. which I hear has really gone up in the past 10 years or so. It's certainly, you know, my hometown is San Francisco, right? It's always location, location, location. Location matters. So one node in ipsilateral superclave is more significant than, let's say, you know, 5 nodes in the axilla level 1 and 2. Okay, all right. So these are the regional lymph nodes. So strictly speaking, these are not, you know, metastatic. Although the word, of course, metastatic is often used even for axillary nodes, okay? But strictly speaking, these are regional nodes. When you're talking about metastatic nodes, when it comes to breast cancer, you're talking about even higher up than the supraclavicular area. You're talking about the cervical area. So that's even farther away, or anything on the opposite side. So let's say you have a cancer in the right breast. If you have an axillary node that's involved with breast cancer in the left axilla, even though it's just a level 1 node, that's bad. And that's a metastatic node, that's M1 disease, and that's stage 4 disease. Okay, so anything on the opposite side is considered metastatic disease with all the, unfortunately, poor prognosis that comes with stage 4 disease. Okay, so regional nodes is what we're focusing on, and many of you are like, okay, well, okay, level 1, 2, and 3, what does that mean? Does that mean like, you know, United Airlines, you have like different levels of, you know, but these are the levels, and these are what the surgeons see in dissection. The anatomy here, this is your landmark, which is the pectoralis minor muscle. So level 1 are these nodes, which are going to be, and remember, axillary dissection is level 1 and 2, lateral and inferior to the lateral margin of the pectoralis minor muscle, that's a level 1 node. Level 2 node is between the lateral and medial margin of the pectoralis minor muscle. It can also be posterior to the pectoralis minor muscle, or between the major and the minor muscle, and that's called interpectoral node, aka Rodder's node. And then the ultrasound is placed here, kind of under the clavicle, but the lateral portion of the clavicle. And then in our practice, we actually go out of our way to tell the surgeons if you have a Rodder's node, because while that is strictly speaking a level 2 node, the surgeon usually wouldn't go and remove that unless we tell them, him or her, that is involved, okay? And here's an example of a Rodder's node that we saw, kind of nice delineation between the different major muscle and the minor muscles. If I would ask you the type of lymph node, like 1, 2, 3, 4, 5, 6, what do you call this? I think it's a 6, right? Because there's no fatty hollow. So it's not that big. A few millimeters, you know, I don't know, 5, let's say 6, 7 millimeters. But the fact that there's no fatty hollow, you know, is very suspicious. And this was a tumor involved node. So that's the Rodder's interpectoral node. Level 3 is medial and superior to the medial margin of the pectoralis minor muscle, okay? And the ultrasound, we place the ultrasound transducer here, which is adjacent to the medial portion of the clavicle. So you can see that the word infraclavicular is confusing, okay? And that, therefore, levels 1, 2, and 3, it's what we're gonna talk about in the 6th edition of BioRads and hopefully radiology in general. And for sure, this is what our clinical colleagues, especially the surgeons, are using, okay? Levels 1, 2, and 3. Okay, so formerly known, the artist formerly known as Prince, the node formerly known as the infraclavicular node is level 3. So sometimes, you know, maybe you get a little lucky and you can get multiple nodes in the same plane. And you can get, let's say, these two are the lateral portion, level 2 nodes, and this one being a level 3 nodes when you get really lucky in one plane like that. Okay, so you can always tell between a level 2 and level 3 node. Those of you who remember BioRads, and I know some of you have seen various editions of BioRads, there's an FAQ version portion, right? A frequently asked question portion in BioRads. And this was actually a question that came up. Someone sent this to us. Can you always tell between a level 2 and level 3 node at ultrasound? Well, the answer is no. You know, your mother or your father taught you when the question's asked that, can you always tell? The answer is no, you cannot always tell. And I'll share with you, you know, the challenges that we have, right? I share with you, you know, our classic cases, but also, of course, life is life. And to say that practice makes better, but sometimes it's putting in multiple pieces together and learning, you know, over the tincture of time. And here is a node that we thought was a level 2 node before neoadjuvant therapy. And then here, you have to be there real-time scanning, you know, looking at the anatomy to determine that. But after 2 courses of neoadjuvant therapy, now, you know, different technologists, different radiologists, maybe, now we're thinking that this is a level 3 node, this little, you know, thing left after neoadjuvant therapy. And our surgeons kind of want to know, it matters in terms of staging, right? The TNM staging. And in this particular case, we happen to have an MRI, okay? And the MRI, I'm labeled for you the major muscle and the minor muscle. Can you see that okay in the light? Kinda. Okay, I'll try to outline it here. It's a little bright in the room because we have the beautiful sunshine. But let's say here's the major muscle and here's the minor muscle. Bottom line here is that you see this little doodad here? I think that was Dr. Evans' term, doodad, not a Bio-Rad's term. Everybody see this little piece here? Okay, so go with me here, okay? That this is the node, and if that's the case, this is medial to the medial margin of the minor muscle, which would make this a level 3 node, okay? I just bring this up to show you, we have challenges, and this happened to be an FAQ that somebody submitted to ACR. Okay, and the answer is no, you can't always tell. You do your best, like everything we do in medicine and in radiology. Okay, so MRI may show more precise anatomy, assuming your technique is good, but of course, the beautiful thing about ultrasound, it offers biopsy capability. Okay, another look at the different levels. Green is level 1, red is level 2, and yellow is level 3. And here's your pec minor muscle. And then you have sharing with you our protocol at MD Anderson currently, and this has evolved over the years. And it's evolved really to sort of be cost efficient, time efficient, but hopefully comprehensive for staging of our patients. So currently, when we have an index malignancy, we would scan the ipsilateral axilla levels 1, 2, and 3. We also scan the internal mammary chain, which is here shown in blue, okay? And if any of these are positive or suspicious looking, then we would add the supraclavicular, which is here, the purple nodes up here, okay? And we do that only for the ipsilateral breast. When I first got to Anderson, which is about 10 years ago, we did that bilaterally, okay? So things have changed. And we used to do supraclavicular routinely bilaterally. Again, evolution over time, okay? Cost effectiveness to show is it really justified. So we do less now. But the difference is that instead of the one situation when we would do bilateral is when we have inflammatory breast cancer cases, and because they have a high propensity for bilateral disease. And in those cases, we actually had those only constitute about 2% maybe of all breast cancers in this country. But in our practice, we happen to have a lot of them because we have specialty clinics for that. So quickly speaking, these are the ribs, which makes this, anybody? An internal mammary node between the ribs. Okay. And do we biopsy these nodes? I talk about ultrasound being really, really good for biopsy. And when you biopsy, is it diagnostic? Well, we do FNAs at our institution, not core biopsies. A few core biopsies have been done. I'm going to talk about that offline. But we almost always do FNAs, fine needle aspiration biopsies. And here's one of our reports about our experience there to show that, yeah, it's been safe. And yeah, it's diagnostic, with outside of pathologists on site. That's our practice, just sharing with you our practice. And no, it does not mean that with the 6th edition of Bio-Rad that is, you're obligated to do it. Okay, I'm just sharing with you what in our practice is. And here's 2 schematic diagrams of what the transducer looks like. And these are from the article itself. This is an abnormal node. You may use Doppler to help you, avoid the vessels. And here is their needle. But let me show you a biopsy that I did. Which is here, internal mammary chain nodes. I'm going to label for you the ribs, okay? And this is, of course, your node, right? Okay, and here is your needle. Everybody can see it okay in this light? Okay, so there's your needle, okay? And this is actually like you say, well, that's a pretty juicy node, okay, good, that's me. One of my colleagues, Dr. Huang, I recognize her, did a very, very small node, and here's her video. You guys see this node? Okay, you see the needle? And what's this? The beating heart of your patient, right? It's not as beating, okay? As it should be, okay? So you can see how she, I thought it was a very beautiful technical case. I think it was like 6 millimeters or so that she was able to get malignant diagnosis and prove it to our clinical colleagues for the purpose of staging and subsequent treatment, okay? All right, so supraclav, that is bound inferiorly by the bony structure that is the clavicle, medially by the internal jugular vein, and laterally by the omohyoid muscle. So supraclavicular adenopathy looks like adenopathy anywhere else, is anatomy, anatomy means you're scanning real time, right? You know where your transducer is. So this is your supraclavicular node. Okay, so we talked about BI-RADS already. We talked about the fact that 6th edition is upcoming. And in the 6th edition, we'll expand the discussion on lymph nodes a lot, okay, a lot. Really in ultrasound and in MRI. And all of these anatomic regions will be discussed in BI-RADS, okay? Note that ultrasound is the only modality that sees all of them, that can be used to image all of them, and it can be used to biopsy them. Mammography, you're really talking about intramammary node and level 1 node only, maybe. MRI, you can see all of them with the exception of supraclavicular node. And the reason for that is not so much MRI cannot image it, it's just that most MRI protocols don't go that high up. It doesn't include the supraclavicular region. So when your protocol doesn't include imaging that region, you're not going to see adenopathy there, right? But ultrasound is one that we could be used to image all the areas and to guide biopsy. And the cortical-hilar relationship is going to be stressed. We're not going to say the levels 1, 2, 3, 4, 5, 6, no. But the concept of the relationship between the cortex and the hilum. So here is our internal mammary node that you already saw earlier. This is your supraclavicular adenopathy you saw earlier, and this is an axillary level 1 node with a compressed hilum at normal cortex. These are all tumor-involved lymph nodes in the regional lymph nodes, affecting the end part of end staging. Okay, so going to the last part now. Anybody know who she is?
Anna Winter.
Anna Winter. I was going to test Dr. Evans to see if he knows Da Vinci as well as Anna Winter, but of course, Dr. Parkinson, oh, Anna Winter, of course, who doesn't know? Okay. Okay, so Dr. Parkinson, where is she?
Where is she in that photo?
Yeah. Where is she in that photo? She looks glamorous, right?
It's very glamorous. She's, it's like she's in a forest someplace with the paparazzi.
Okay, there's paparazzi, there's a lot of gardening, okay? And of course, she's the Vogue editor. Anybody see The Devil Wears Prada? With Meryl Streep, I think that was supposed to be, maybe she was the inspiration behind that. But yes, Anna Wintour, and she was at a glamorous event, which is the Met Gala. Okay, and this is the Met Gala from this year. Everybody know about the Met Gala? Am I the only one who reads all the, Instagram or paparazzi magazines? Okay, the Met Gala is a fundraiser every year, and it's for the New York Metropolitan Museum of Art's Costume Institute. And, movie stars, famous people. It's basically a fundraiser, and they get really, really dressed up, and, lots of paparazzi, okay? And there's a theme every year, okay? And this is 2024, which I thought was a particularly beautiful theme. The theme of this was modeled after this short story called The Garden of Time, very interesting, where you're looking for beach reading, I guess we're not summer anymore, right? I forget because it's so sunny here. For any kind of reading, okay? But it's predicated this year on this book, The Garden of Time. And the theme was like, garden, forest, the passage of time. Okay, that was the theme. And I bring these to that. She's the Vogue editor. I bring this up because she organizes the event, is what I'm trying to say. One of the major organizers. And here are 2 particular movie stars. I like their costumes, dresses, I should say, costumes the best. And sorry, no conflicts of interest. No commercial bias here. Not endorsing anybody, just to show you the beautiful clothing. And I say that on the concept of theme, okay? Because now in breast cancer, we have theme as well. What am I trying to show you is the theme here? Wellness, right? We all like wellness. I heard that you have massages here, at the Huntsman Institute. So I want to work here too. I'm gonna, contact Nicole and Phoebe later for potential, okay? So wellness, maybe you're relaxing, the coffee's going away, the laptop's going away. So the theme here is de-escalation, okay? Less is more. It's a current theme we have in breast cancer and breast imaging. Less is more. So I'm from California. We want to be zen by the beach. The idea is to strike the right balance, to treat breast cancer that is not too much and not too little. I mean, enough, obviously, you want to get rid of the cancer, but it's often less is more. That's the theme du jour about many things. And for the sake of time, I won't be able to talk about neoadjuvant therapy, but I'll just talk a little bit about the axilla, okay? Because axilla, of course, is where a lot of lymph nodes live, and less is more now for the axilla, okay? So let's see here, surgical excision of regional nodes. Why do we get rid of lymph nodes? Well, we take them out because we want to get rid of cancer, reduce cancer. And also it's very important information for us to prognosticate. Now, basically, these are the two big ways of lymph node of taking care of lymph nodes surgically. The central lymph nodes, and then you have the full axillary nodal dissection. Central lymph node is just a few. Axillary lymph node dissection is a lot. I don't know, what's a few? I don't know, 2, 3, 4-ish. Many more nodes, you're talking 15, 25, 35, 40 sometimes, okay? So a little or a lot, those are the two big ways, if you will now, of surgical excision of regional nodes, okay? Now, this is the ACOSOC Z11 study. Let's see if I push this, it'll be, okay, let me go back to here. Okay, so this is the ACOSOC Z11 study. I don't know if I can get rid of this part, but I'll proceed. Oh, here we go. You call, and this is great, you know, all the wellness in this place, right? Permeating. Okay, so ACOSOC is American College of Surgery Oncologic Group. And these are multi-institutional trials run primarily by the surgeons, but often multidisciplinary. This is the famous one that looked at basically axillary nodal dissection. Is that indicated if you just have like early stage cancer? Where are we? You know, T1 to T2, so these are small cancers, not big cancers. Of course, no metastases. And long story short was that after 9.3-year follow-up, the two groups survival was the same. Okay, so you may not need to do full nodal dissection. You may just have a little bit of positivity at sentinel lymph node biopsy. Okay, I know I went through this really quickly and for the sake of time, but this is kind of, I would say established now. This is 2017 when it came out, was not yet so established. I think it's pretty established now that you don't need to do so much, okay? But this is very early stage disease, T1 to T2. These are small cancers, small invasive cancers. Now, I want to just talk about really briefly two current trials. This is 2023, so very recent. And this is the SOUND trial here, which stands for this, sentinel lymph node biopsy versus no axillary surgery. So these patients are different from the ACOSOC study because these patients had to have negative axillary ultrasound versus the Z11 trial, they did not have to have that, okay? And of course, we radiologists are the ones, you know, for the most part, doing these ultrasound, at least in the United States. So just to show you all of, especially the trainees in the room, right? The role of radiology in the patient's care. So these are still small cancers, small defined as 2 centimeters or less. And here are the numbers of the number of women in each arm. The endpoint was disease-free survival at 5 years. And the conclusion was that after the 5 years, in this randomized clinical trial, the omission of axillary surgery was non-inferior to the sentinel lymph node biopsy, okay? So these are the ones with negative ultrasound to begin with. Okay, so again, you know, maybe less is more. Maybe you don't need to do the full lymph node dissection. And here is another trial, the SENOMAP trial, which published in 2024. These results, it really started the group collecting data in 2015. Survival and axillary recurrence following sentinel node positive breast cancer without completion axillary lymph node dissection. So in these patients, they actually had fairly big disease, T3 disease even. They're getting to the bigger cancers now. And they actually had, all of them have 1 or 2 sentinel lymph node macrometastases, defined as greater than 2 millimeters. So they have, you know, larger disease than just the really, really super early disease, okay? So these are the number of patients. The bottom line is that many of them, 90% had radiation to the axilla. So yeah, less is more, but recognizing that adjuvant chemotherapy, adjuvant radiation to the axilla, all that plays a role, so it's complex, okay? And the conclusion of this trial is that median follow-up of 46 months, so several years, the conclusion was this, that the omission, not doing completion axillary nodal dissection was non-inferior using overall survival as primary endpoint after a follow-up median of 47 months, okay? So less is more, even in these larger cancers, with the caveat that 90% in this study received radiation to the axilla. So the adjuvant radiation, adjuvant chemotherapy, definitely important, but maybe less surgery. Okay, that's the take-home point, de-escalation. And here is the ACOSOC Z1071 trial. This one looked at whether we can use sentinel lymph node biopsy only for the neoadjuvant therapy population. And the answer was no, because the false negative rate was too high. So we cannot apply the Z11 results to the neoadjuvant chemotherapy population, okay? But I'm going to talk about something we do at Anderson a lot, briefly, okay? And I'm gonna talk about this first. Anybody know what this is? Goldilocks? Anybody know the story of Goldilocks? Well, a little girl, she goes into the forest, she goes to the bear. I mean, why would a little girl go to a bear's house, right? You know, it doesn't make sense, but she did. And she meets Mama Bear and Papa Bear and Baby Bear. And, you know, she tries the bed, and one bed is too soft, one bed is too hard, one bed is just right. You know, she eats their porridge. One bowl is too hot, one bowl is too cold, one bowl is just right in terms of temperature. Okay, so I say that Goldilocks and the Three Bears because remember we talked about these are two ways of surgically excising lymph nodes, regional lymph nodes. Well, turns out maybe there's something just in the middle, not too cold, not too hot, not too hard, not too soft. And that is what we call the TAD, the targeted axillary dissection. Okay, so target axillary dissection means you remove the central lymph nodes and what we call the clipped node. Okay, that's the TAD, targeted axillary dissection, or TAD if you're one of the cool kids. Okay, that is something that's relatively was a trial when I went to Anderson 10 years ago. I see in the last 5 years that is becoming more and more clinical practice. Okay, not just trials only now. So what is it? Is central lymph nodes plus the clip node, aka the marked node. That's another term for it. And the marked node basically is that malignant node in axillary level 1. That's it. And who determines that most of the time is us, right? The radiologists. Okay, so the idea is that we want to do less and less and less because of the theme of de-escalation. Less is more in many ways. And let me show you an example of a clipped node or a marked node that you want to remove in conjunction with your central lymph nodes for part of your targeted axillary dissection. Here's the lymph node, abnormal cortex. This is the clip, okay, or the marker. That's echogenic right there. And here it is in a mammogram in the axilla. You can see the abnormal nodule. Okay, so make it bigger. Everybody see the node? Okay. So that's your marked node, your clip node, and that's the marker. All right, so why do we care? Why do we want to do this? Why is less and more? Well, less invasive is always good, but in particular, what are we looking at here? Lymphedema, right? And that's a significant morbidity, okay? No, it doesn't affect mortality. I don't think people die from lymphedema, but of course, it's morbid. And I have known both, you know, people who were colleagues and, you know, patients and et cetera, lymphedema, okay? So of course we want to maximize survival, but we also want quality of life, right? So it's mortality we want to look at, but also morbidity. We recognize the lymphedema is a significant cause of morbidity when you do extensive nodal surgery. So when we don't have to, and we don't negatively impact survival, we don't want to do that invasive surgery in the axilla. Okay, that's the bottom line of all of this, really. Okay, so especially when we have more and more neoadjuvant therapy now, we want a downstage disease, less invasive nodal surgery. So the data from our group, and this was shown in the multi-institutional trials as well, that while central lymph node false negative rate is too high, which is 12.6, if you add the addition of that clipped node in the surgery, that false negative rate drops to a low number. 2 in this publication. I think across the country, all comers speaking, you're looking at 5%, which is still considered to be acceptable. Okay, so maybe we can avoid lymph node dissection in these neoadjuvant therapy patients, and maybe avoid the potential morbidity of lymphedema. Okay, so is the clipped node always the same as the central node? This is a meta-analysis, and the answer is no, it is not always the same. And, you know, we won't go into all the data now, but the clip node can be different from the central node. And therefore, it is important. In our hands at Anderson, clip node was not the same in about 23% of the time. And that's been sort of, you know, the average across all studies as well. So we radiologists would localize that clip node for our surgeons to make sure he or she remove it as part of the TAD procedure. Okay. And just a review article from our group of what we do this very routinely, and I won't go into details of that. But residents, next hour, I'd love to talk more about that, you know, if you have an interest in hearing more about that, okay? So let me go to the very, very last part now, which is a little bit of the outcomes-based research that we've been doing. And before I do that, let me just take a little break with all of you to look at this video, a little summary of the various points that we made, teaching points. Here's the pectoralis minor muscle, this internal mammary chain, level 1, level 2, level 3, supraclav. And let's pretend that we have a tumor. Let's say this is our tumor. And that, I know it's small. Can you see things moving here in this light? These are cancer cells. And let's say this is a normal node. This is still a normal node, green as the cortex, but then you start having tumor involvement. And then you have more tumor involvement. And then even more, and then you have complete effacement. So that's the general idea of the spectrum of change, okay? All right. So we talked about the regional nodes. I said that cervical is even higher up, and that's already, M1 disease and stage 4. I talked about everything in life like neat and orderly, right? But as we know, life is not neat and orderly, it can be messy. So my question is, do your lymph nodes actually go from 1 to 2 to 3 to, supraclav? Or can it skip around? Because a lot of what we do, in particular, the sentinel lymph node biopsy, we're counting on level 1 being the first spot that it stops, right? Like almost a bus stop. We're counting on that to happen. But does it happen all the time? That's the question. And as we now know, whenever someone asks you, does it happen all the time? The answer is never say no, never say never, never say always in medicine, right? So the idea is that this is the progressive pathway when a cancer reads the textbook and behave as it should, okay? But sometimes, some of them will go rogue, and instead of staying home and studying on a Saturday night, it will go to a club, downtown, Salt Lake, okay? And it will do something different. So this is what we call the skip metastasis. And we looked at Anderson at our patients to see, well, does it happen? The answer is yes. How often does it happen? So in our study, we had 1,300 newly diagnosed, untreated invasive breast cancers. They had ultrasound exams. And let me show you what I mean by skip metastasis, okay? So instead of progressive pathway, we kind of go to the level 1, level 2. Here's our little, cancer cells traveling, level 2 here. And cancer cells traveling more to, here is level 3, right here, the little red dots going up here to the supraclavicular region, okay? But the skip pathway instead will go rogue, okay? So let's say, where is my cancer cells? Basically, let's say what happens when it goes directly to level 3. Does that happen? And if you do that, how does your sentinel lymph node biopsy, work clinically anymore, right? Those are the questions. So first, does it happen? And how often? And the answer is yes, it happens. And how often? These are all numbers of how often. We have 1,300 cases altogether, all comers speaking, but 470 actually had nodal involvement, okay, and the rest didn't. So, and we have 34 cases of skip metastasis. So if you use 1,300 as the denominator, that's a percentage of frequency was 2.6. But if you use 470, which are the number of patients who actually had any nodal metastasis, instead of the all comers, which is 1,300, 34 out of 470 is 7.2%. Lower denominator, higher percentage, okay? So which depends on how you read these, how you analyze it, somewhere here. So less than 10%, but not 0 is the bottom line, okay? So, and when they happen, most of the time they skip and they go to the supraclav, like here, from level 1 or 2, skipping 3, going to supraclav. Here from level 1 to the supraclav, skipping 2 and 3, okay? So the idea is that maybe we should do some sort of imaging to look at all these regions, because when we rely on the principles of sentinel lymph node, a small percentage of the time, these tumors are not behaving exactly as they should. Just a thought, okay? And have you ever wondered, like, your patients are cured now, quote unquote, they're survivors, and like 10 years later, they come back with recurrence, maybe in the breast, maybe liver mets? Like, what's happening during all those years? So one hypothesis is that maybe, just maybe, these are all conjectures at this time, maybe we're undertreating them at the time of diagnosis. So maybe these additional stuff beyond the classic pathologic staging using surgery may help triage those patients. So we need to do more in them. I mean, I'm talking, of course, of more adjuvant chemotherapy. Okay, so just food for thought, if you will. So a little bit of other studies that we've done. We have a lot of PET CTs at our institution, so we looked at how well PET CTs, MRs, etc. work when we don't want to biopsy or when we cannot biopsy for whatever reason. And these were the results. And you can see that ultrasound was pretty good, considering that it's accessible. Patients, patients like it because it's comfortable for them. We could biopsy. CT alone, not so good. Okay. PET CT, however, when you add the PET part, quite accurate, 97%. But look at the MRI, it's the winner here, 100%. Okay, that's super good, as my 10-year-old nephew would say. Remembering again, that was super good for internal mammary nodes. Not so super good for supraclav, just because we tend not to include that region, in our breast MRI protocol. But internal mammary nodes, you just don't want to biopsy, you don't feel comfortable, they're really small, whatever reason, MRI is good, is accurate in terms of saying cancer or not cancer. Okay, so example of internal mammary nodes, here's the PET CT on the bottom, and on the top, on the axial, on the sagittal is your MRI. Okay, internal mammary adenopathy, you should choose not to biopsy or cannot biopsy for whatever reason. Okay, this one I like a lot too, because it kind of came from our group in terms of saying those type 3 and type 4 nodes, so I need to biopsy. Okay, and remember I said, yeah, especially when it's lobular, especially when you have a cancer, but especially when it's lobular, okay, that's just kind of our feeling. But here's data that substantiated our feeling, if you will. So the idea is that lobular cancers, you have loss of E-cadherin, which is a adhesion molecule. So you have these cells that just kind of dispersed. They're not clumped, okay? So harder to recognize. And that's true in the breast. That's also true here. But this is a photomicrograph of lymph node, of lobular cells, in the lymph node, okay? The brown, the staining. So the idea is that, well, if that's true in the breast, that I don't really have a mass, maybe that's also true in the lymph node. Okay, that's the idea. Because I don't have adhesion, I don't have the E-cadherin molecule. So we were thinking that, going back to the types, so maybe instead of a big ball of tumor cells, which would be more like the 5 and 6, maybe lobular act more like the 3 and 4, like the more, sinewy, infiltrative things, okay? So, versus 5 and 6 were more likely to be the ductal subtypes. That was our hypothesis. And 3 and 4 is more likely to be the lobular subtypes. So basically we said, do we see that in our data? And in our data, and the answer is, yes, we do, because I'm showing it, okay? But seriously, is that this is the data, this was an HIR a few years ago, okay? So if you focus, this is lobular, and this is ductal. And you can see that, let's see, these numbers here, morphology, okay? So morphology of the most suspicious lymph nodes. Type 3 and 4, lobular, it was about 70%, versus ductal was about 29%, 30%, so 70-30-ish, okay? More likely to be lobular. But type 5 and 6 was flipped, the exact opposite. Lobular, 30%, ductal, 70%-ish. And that was statistically significant with a p-value of less than 0.05. Okay, so in other words, our hypothesis was substantiated by our data in a statistically significant fashion. Okay, so you're like, okay, well, that may, help affect your management. And next time you see those subtle cancers, those subtle lymph node changes, you may biopsy them. So that's one thing I want you to take away. The other thing is to say, when you have a question, you kind of ask it. You say, hey, can I look at my data and find out? Whatever the question may be, and that may impact your patient management. Okay, so that's what we did, and that's why I like this particular study. And in general, of course, it's harder to detect lobulars, whatever subtypes. So very, very last case. What do you guys think I'm showing here? I'm talking about lymph nodes here, right? Same patient. Baseline later. What's up? What's changed? And I'm not talking about subtle calcifications or anything in this very bright room. Nodes, right? Everybody see the nodes here? Okay. What if I were to tell you this is only like, 4 months apart? What are you thinking? Something that hit us recently. Vaccination. I heard somebody in the middle of the room say that. Wonderful. So this is meant to be 3 weeks after the second dose of COVID-19 vaccine in her left arm. That makes sense. It's her left arm. So we're looking at COVID-19 vaccine in terms of benign adenopathy. Big news, right? Big news, 2020, 2021, I guess, right after the vaccine. And of course, we had a cancer center. We had a lot of cancer patients. So we have nodes that are cancer and nodes that are vaccine related. So what gives? So are there features I can tell? So what we did was we looked at 77 consecutive patients with benign adenopathy. We know that through follow-up. And we have 76 who had, cancer lymph nodes. So the bottom line is that when we did the analyses, you can see that the vaccine nodes, they're adenopathy. It's just not cancer. They kind of could be type 3, type 4, type 5, or type 6, the breast cancer could be any of these, and you have 5 or 6 types as well in appearance, versus the vaccine-induced adenopathy tends to be more like the 3 and 4 enlargement, and not the 5 and 6. And when we did ROC curve, receiver operator characteristic curve, remember we said that the cutoff was 3 millimeters, okay, for normal, abnormal, but if you allow a little bit more, 5.4 millimeters, then you can kind of help distinguish between adenopathy from vaccine-induced, which is benign, versus the cancer involvement, which is malignant. Okay, so these are receiver operator characteristics curves. So here is a vaccine-induced adenopathy. This is thickened more than 3 millimeters. Was the type 3, it was 5.3, just underneath the 5.4. True story, I didn't make that up. That was in the publication. And with follow-up at 5 months, gone back to a type 2 now, only measuring 2.4 millimeters, less than 3 millimeters, okay? As opposed to this type 5 focal cortical bulge here, which is really thick at 15 millimeters, this was a cancer node, okay? And again, common sense kind of tell you all this stuff, but it is nice when the data substantiates it, right? That you can say it's evidence-based. So on that note, I hope maybe tomorrow before my plane, I get to go see like the High School Musical and do a picture, like Zac Efron and Vanessa Hudgens. But in my part of the world, right, this is what record are we talking about? Record-breaking country music. Dr. Parkinson, no, I can see it already. It's Beyonce, right? What was the song? I will start singing it. This ain't Texas, okay? So what about this song? Does anybody know this song? Anybody from the 90s? Yes, the future's so bright, I gotta wear shades. You guys know the song? I think maybe even the 80s. Maybe it was even the 80s now. So I hope that your future, and I know it will be very bright. I mean, just look at where you are and your wonderful teachers, your wonderful patient, your clinical materials and everything here to all our trainees out there. Your future's so bright, you gotta wear shades. And this is me kind of wearing shades, kind of, okay? This was our eclipse that happened around the country, but in Houston, we had a partial eclipse. And I actually didn't take this picture. One of my colleagues gave it to me, okay? But this is me looking, I thought cool, but now I think nerdy as I put it up on the big screen, okay? But here is a real photo of the total eclipse, really given to me by one of my colleagues. Her son took this one. So that was April 2024. So this is our Anderson building. And I like to say, mi casa es su casa. I know there are many Spanish speakers in Utah as well. Meaning I welcome you. My home is your home to visit or to contact me at any time, virtually or in person. And we can go out and get nice Tex-Mex food. Okay, so thank you again to my host for kindly inviting me. And it's my pleasure to be here. Thank you very much.
Thank you so much, Dr. Leung. Does anybody have any questions?
I was just curious if you consider the accuracy of MR and ultrasound for axillary nodes. For example, if you have a patient who came from another location, they just have a breast MR, no axillary ultrasound. Would you accept normal looking nodes on MR, or would you recommend an axillary ultrasound?
Okay, so a great question. I'll repeat it real quick, which is MRI for the axilla. Do you need to do ultrasound necessarily? Okay. I referenced one article how showed that MR was really good. I'm sorry, went over that quickly. That article particularly was looking at extra axillary nodes. So we looked at internal mammary and supraclavicular in particular, and not the axilla. Okay. So that data may not apply to the axilla. But to answer your question, in our institution, if it looks completely normal, then no, we would not do it. Okay. I just think that the challenge sometimes is that there are many borderline cases. You know what I mean? When it's abnormal, it's abnormal. I don't know if your clinicians will require biopsy still. Our probably would still. Okay, and we would do ultrasound, quote unquote MRI directed or second ultrasound and do a biopsy. Just depends on your clinical clinicians. So when it's stone cold normal, no, we don't do it. But challenge for us is many times of the gray zone, the equivocal parts.
Because of your findings with TAD, do your surgeons like you to biopsy every single abnormal, not every abnormal lymph node, but any patient who has an abnormal axillary node on ultrasound, you biopsy that and you clip it?
Okay,
Correct.
it's another great question, which is the fact that, let's say you have 4 abnormal nodes, okay, another one. Do you biopsy all of them? And if you don't, which one do you choose to biopsy and be your clip node? So if I got $1 or, even a quarter, that's a very common question, it's a great question. The answer is we biopsy only one and not all 4. Our clinicians, I guess, you get one, you say the others, they take that, and the data has shown that's okay. And the next question will be like, how do you know which one is the clip node? Okay, what we do is we basically take the one that's looks the most suspicious that we can access technically. Well, how do you know that's the one? Okay, well, we call that the clip node, and the data, which is probably 10 years now, 10 year plus, show that that works. Okay, so I don't think there's magic, we don't know, we cannot look with our eyes histologically, but this is our practice, and the years of data we follow show that that's acceptable. So that's what we call it. We actually basically we as human beings are saying that's a clip node instead of, anything at the biological level, if that makes sense.
I remember at an SBI meeting in one of the breakout sessions, there were some institutions that weren't even biopsying very suspicious nodes because they were going to do a sentinel lymph node only.
Yes.
And they said, so don't do that. But it
Yes.
seems like with the TAD findings, you would always biopsy a suspicious node.
Yes,
Is that
okay.
correct?
Yes, in essence, Dr. Parkinson mentioned, if you're gonna do like the Z11 trial, the surgeon's gonna do the sentinel lymph node biopsy system and don't go there and potentially take the patient away from that potential even. Because we don't have time to talk about the debate now, that's Memorial Sloan Kettering practice. So they don't do TAD and they don't do the ultrasound. And different clinician thoughts. I would say if I have the 10 seconds to remark on this, is that consult with your surgeons and your oncologist to see, what works for your particular institution.
I have a couple of quick questions. Matt Covington has done a lot of great research with FES PET on ILCs. And he will find nodes that are abnormal on the FES PET that we, on both MR and on ultrasound, might look normal. In my experience in retrospect, and I don't know if Nicole has this or anyone else who's on, you mentioned that sometimes you'll see like the type 3 hypo, but like maybe more hypoechoic. Sometimes I feel like there's almost a stippled appearance of like hyperechoic in retrospect. Maybe I'm just seeing the hypoechoic, but have you ever noticed that? Of like when there have been nodes? This is just anecdotally, but I think, how can I better identify those nodes that he's finding that we didn't?
Okay, I think if you heard the question, so I will repeat, I don't know the answer to that, and maybe give us more material to think about, okay? We have been thinking about like other ultrasound features that can tell you extranodal invasion, because some of our clinical colleagues care about that, as a prognostic indicator. But in terms of stipple hyperechoic, we have not encountered that, it hasn't, but maybe we just didn't look for it, so thank you. Maybe we could collaborate and do our projects together.
It's only anecdotally on a couple
Yeah.
cases, but, and then a quick question on your COVID nodes. COVID adenopathy is obviously less, now as people are getting vaccinated less and we're living with COVID. But you do still see, vaccinated cases. When you use the cutoff of 5, are you using that in like a new cancer ipsilateral adenopathy? You're only biopsying if it's over 5, or do you still biopsy if it's over 3 and it's a new cancer?
Okay,
Or are
so
you talking about just isolated adenopathy?
So, I am talking really about the isolated adenopathy. The cancer nodes, it's hard, right? Because, most of our patients and most of our clinical colleagues, they don't want to wait, even though there's a decent chance that could be, just because, they have cancer and they want to get on with their lives. So follow-up is not really an option. So it still tends to stick needles in those patients.
Great. Any other questions? Well, thank you so much, Dr. Leung. What an honor. And we have Dr. Parkinson here too. I mean, this is a powerhouse for the residents, just so you know, of like SBI peeps. So thank you very much. And we look forward to your resident lecture.
Thank you guys for being here, okay?